So let's move away a little bit from diagnosis and biomarkers to the practical aspects of managing patients with prostate cancer. We know that, like we've all talked about, there are appropriate patients that don't need to be treated, and the concept of active surveillance is real. To me, I think it's a little bit interesting to me that we're making active surveillance protocols based upon suboptimal biopsying technique, and I think, again, with the use of markers, with the use of better imaging diagnostic technology, that probably will change. We also know that a fair number of people, 70% of people conservatively, do fine with either no therapy or definitive therapy, whether it be surgery, radiation, cryo, what have you. But unfortunately, there are going to be patients that will progress, and you know, we'll talk about a little bit, because there's been some trials, some papers, some abstracts that have come out over the past year, specifically dealing with patients with metastatic prostate cancer, we all know that androgen deprivation therapy continues to be the mainstay of advancing prostate cancer, primarily in people who are metastatic, but also, especially where the urology world has used them, in patients with biochemical recurrence, rapid PSA doubling times, unfavorable pathology at the time of surgery, a lot of different parameters through there. So in terms of androgen deprivation therapy, Neal, the standards are what? LHRH agonists versus antagonists. I mean, you've done a lot of work in this. Give us some of your perspectives in terms of the advantages, disadvantages of antagonists versus agonists.
Yeah, it's an interesting question. You know, seminal work, Huggins and Hodges, everybody talks about it. 1941, bilateral archaeectomy, metastatic patients, we see the palliative benefit. Then in the early 80s, we get the agonists, which basically, not the ideal drug to have designed at the time, but we did that because of, from purposes of pharmacological distribution. So we get a surge, and then we shut down the hypothalamic pituitary gonadal axis. And the endpoint for approval back then for all of the LHRH agonists was getting a T level less than 50. And the 50 was chosen because of the sort of the insensitivity of our ability to detect T any much lower than that. Fast forward to 2009, we get the approval of the first antagonist that stays on the market. There was one a little earlier called Aberelix. You now have an 09 Degarelix, which is a true antagonist. So you don't get the surge. Similarly works at the level of the anterior pituitary. And again, pharmacologic endpoint, basis for approval by the FDA, 50. Now, let's talk about 2012 and on, and we're recognizing, at least in our CRPC world, that the lower the T, at least in the castration-resistant patients, lower T matters, or blocking that little bit of circulating T at the level of the androgen receptor, it matters, it affects survival. So we're still left in this sort of conundrum about monitoring T. Historically, our colleagues have rarely checked testosterone levels, and I think now it's fairly non-controversial to recognize that you've got to check testosterone at baseline, and if the PSA is going up, you need to know what your T levels are. So I think there's been no clear-cut evidence that any one particular ADT strategy gets persistently better lower T levels. There's some studies that have come out. The real question is, looking at a lot of this data, are there other metrics involved between the agonists and the antagonists in terms of the impact of FSH, the surge phenomenon, the continuity of T suppression? There's been some very nice data that was recently presented by Albertson and others. I participated in this, a meta-analysis of the Degarelix data, looking at about 6 or 7 trials, and what we saw was a decrease in cardiovascular events compared to agonist trials. Small numbers, a little less than 1,000 patients, but there seems to be a potential signal. So we're again looking at a prospective study. Is there a difference between antagonists and agonists in terms of cardiovascular implications? Is there something happening at the cardiac myocyte level? Is it an FSH phenomenon? Is it affecting neovascularity? So I think I can't give you the clear cut. The bottom line is, thanks to labs like Ganesh's and others, we're looking further into this. I think the big take home for me, and I'll stop talking here, we're getting winded, but is checking your T levels and knowing what they are, in both in the androgen sensitive and the castration resistant state.
Yeah. And I think a lot of people do now reflexively, if they see a bump in their PSA, although unfortunately that may mean they're becoming castration resistant, that at least because of these potential surges, especially with the agonists, that you do get some breakthrough, and it is worthwhile to maybe switch them over to a direct antagonist. And then also now you've got a couple companies that are looking at some oral antagonists, which I think are going to be very interesting. So.